Let's move on now, and we'll talk about the individual ligaments. We're going to start with the lateral ligamentous complex. I know some of our fellows like to call this the low lateral ligamentous complex. It's nice to remember they're low. I don't think we should call them low lateral. They are the lateral ligamentous complex. There are three major ligaments in this particular complex: the anterior talofibular, the calcaneofibular, and the posterior talofibular. I'm going to show you a couple other minor ligaments and one debated ligament in a little while, but these are the three major ligaments that compose the lateral ligamentous complex. So let's draw them on a skeleton and let's look at them first briefly and then in more detail. This is a picture of the lateral aspect of the ankle. So this is the posterior and this is anterior. We can see here the fibula. We see the oblique short anterior talofibular ligament, the short oblique posterior talofibular ligament, and a longer oblique calcaneofibular ligament. There are some major differences in the construction and the characteristics of these ligaments. First of all, the anterior and posterior talofibular ligament are capsular ligaments. They're in the capsule. That is why when you get avulsions related to them, you end up with ossicles that are contained within the capsule that simulate true intra-articular bodies, which they are not. The calcaneofibular ligament is extracapsular. It reminds me of the fibular collateral ligament of the knee. All right, so it is an extracapsular ligament, not intimate with the joint capsule. Perhaps more important, the second characteristic that is different among them. The anterior talofibular and posterior talofibular ligaments are related to one joint, and that is the ankle joint. So they are stabilizers of the lateral aspect of the ankle joint. The calcaneofibular ligament is related to two joints, the ankle and the posterior subtalar joint, this joint right here. So it is a stabilizer not only of the ankle joint, but of the posterior subtalar joint. When I was in medical school, I learned a rule that if you're dealing with injuries of the lateral ligaments, the calcaneofibular ligament was almost never injured alone, that the injury began with the anterior talofibular and proceeded to the calcaneofibular. And that is true for injuries of the ankle. But you can have injuries of the posterior subtalar joint, where the only ligament that is disrupted is the calcaneofibular ligament, and the talofibular ligaments remain intact. So that is something to remember about these ligaments. And we'll get back to this anatomy in a little while and show you some images of it. Now, I'm going to add to the drawing two of the four syndesmotic ligaments. And that is the anterior tibiofibular ligament and the posterior. I'm not going to talk about them just yet, but I'm going to do one more thing to this drawing, a simple thing. I'll put a line through it and show that some of the ligaments are high and some of the ligaments are low. Now, I don't know where each of you goes to learn your musculoskeletal knowledge, but I'll tell you where I go. I go to USA Today. I really like it, all right? It's good reading. And in USA Today, in the sports section, I hear about all these injuries, and I have absolutely no idea what they are. And for years, and I'm sure you've seen this, for years I heard about high ankle sprains. You've heard about it, sure. I wasn't quite sure. I was embarrassed to ask anybody about it. I didn't know exactly what was the high ankle sprain. I knew it must be pretty high, all right, but I wasn't sure how high it had to be. But I've learned that the high ankle sprain is an injury to the syndesmotic ligament. So maybe a low lateral ankle sprain would be an injury to the low lateral ligaments. What makes the high ankle sprain difficult to define is that it comes in different forms. Not only can different syndesmotic ligaments be torn, and we'll talk about those patterns a little later, but these ligaments can be torn in isolation, that's rare, or they can be torn in conjunction with problems on the medial side, the deltoid ligament. So many of the so-called high ankle sprains I think we read about in the newspaper, USA Today, sports section, many of those that we read about are not isolated to the syndesmotic ligaments. They probably involve deltoid ligaments as well. Well, you know, other things you read there, and you can all tell me what they are: the hip pointer, the Charlie horse, the shoulder separation. I mean, I could go on and on about things I don't quite understand, but I read about it. I still read the sports section. Anyway, so there you have the high lateral ligaments and the low lateral ligaments. Now, to get you interested and perhaps to try to emphasize maybe you don't know everything, all right, I start with this particular image. It looks horrible, and that's my purpose, all right? This is all of the ligaments that you might see if you were the back of a shoe looking forward at the calcaneus without a sock on or even any skin, all right? These are the basics. And right away, you can see you got ligaments running in every which direction here. This is lateral. This is medial. We have the calcaneofibular ligament. We have the posterior talofibular ligament. Here's the posterior subtalar joint. We catch a glimpse of the ankle joint. Here's a tibial or intermalleolar slip, we'll talk about, of the posterior talofibular. We go up higher, and now we start seeing the syndesmotic ligaments, the inferior transverse, and the posterior tib-fib ligaments. So there are a lot of ligaments, and you have to know their anatomy to make sense out of an MR image like this. If you don't know your anatomy, you're going to see these strands of tissue and have absolutely no idea what ligaments you're looking at. But these are the same ligaments: calcaneofibular, posterior talofibular, intermalleolar slip, inferior transverse, and maybe a little bit of the posterior tibiofibular ligament. So if you learn the anatomy, you can identify these ligaments regularly on your MR images. When there is a joint effusion, or if indeed you create one by doing an MR arthrogram, in certain planes, these ligaments traversing the ankle will look like bodies in the joint. Here are three of those ligaments in the coronal plane, and I've labeled them in white so you could see that, but we can see the posterior tibiofibular ligament, the inferior transverse ligament, the posterior talofibular, but here's what they look like in the sagittal image. They look like dots in any single sagittal image, and I'll bet you've made the same mistake that I've made and called those bodies occasionally in the joint. But you can trace them across the joint and realize that they are ligaments. Starting with the posterior talofibular ligament. This is a strong ligament that is almost horizontal, hence we tend to see it on a single axial image. This is what it would look like. It is triangular in shape, broader laterally than it is medially, consisting of individual fascicles that you often see as these lines separated by fat or fibrous tissue sometimes. So we look for a striated appearance of the posterior talofibular ligament. Now, most important, I think, is a landmark we use on the fibula to indicate we're at the proper level for talofibular ligament analysis. That landmark is that concave medial aspect of the fibula. We talked about it earlier. If you have a concave shape to the medial aspect of the fibula, you're at the proper level to be looking for talofibular ligaments. That's a great rule to remember if you're beginning in here, because otherwise you will mistake tibiofibular and talofibular ligaments. So this is the posterior talofibular ligament. Of these ligaments, lateral ligaments, it is the one that is injured least frequently, but it also is a ligament that often looks abnormal. because it's not a small ligament. It always looks sizable. You look at it, it's easy to say it's thickened. More often than not, it is not thickened. That's just the shape of the ligament. There are a couple of small ligaments nearby that I don't think one needs to know, but for completeness, I put them in here. This is a posterior talocalcaneal ligament, this little strand of tissue. This is some work that was done by one of our research fellows. That's one of the ligaments that's nearby. And another one runs from a os trigonum, or the trigonal process, to the calcaneus, called the trigonocalcaneal ligament, and it is this structure right here. So these are smaller ligaments seen in this general area that, frankly, I rarely see or even think about when I look at the MR images of the ankle. There is a part of the posterior talofibular ligament that I regard as the intermalleolar or tibial slip of that ligament. Now, there is some confusion on this topic, because some people have separated the intermalleolar slip and the tibial slip as two different structures, but I regard them as the same. I haven't figured out any differences between the descriptions of the tibial slip and the intermalleolar slip. This is a ligament that is part of the posterior talofib, but goes all the way over to the medial side. So it is going between the malleoli, and it projects like this that you'll see in the back, and here with some oblique imaging we can follow it all the way over to the medial side. Now, the importance of this ligament, I don't know in terms of stability, but I do know that this is one of the causes of posterolateral ankle impingement, that when it gets thick, it can produce problems in the posterolateral aspect of the ankle. So if I know that's the clinical reason for the MR, I'm going to spend a little bit of time looking for this ligament. Fortunately, many of the ligaments whose enlargement produces this posterolateral impingement also produce a secondary finding that I regard as critical, and that is edema in the talus as they go by the talus. So you always look for subjacent edema involving the tibia and talus, because you will often see that when you have a ligament as a cause of posterior impingement. Another picture of the intermalleolar or tibial slip running all this way. So it's just above the main portion of the posterior talofibular ligament. Here's an oblique image showing you that, and you can kind of see it here. It's this ligament running all the way over, in a patient who has an OCD as well. The second of those lateral ligaments is the anterior talofibular ligament. This, too, is a ligament that you can see on all of your exams. Typically, it's seen best in the axial plane, but you can supplement the evaluation by looking at coronal and sagittal images. Now, first, this is the general way it is described. You can see it here. It is running between the fibula and talus. This is what it would look like. Note the shape of the fibula. I'm at the proper level for looking for talofibular ligaments. And for many years, I would accept this ligament as being normal if it looked normal in a single axial image. But I no longer accept that, because I have found that does not work. This is a ligament that has 2 and sometimes 3 bands. I'll show you those bands using this case, but because of that, for me to be sure it is normal, I must see it in 2 axial images and be sure it looks normal in 2 axial. The first of these, by the way, are transverse images. This one is slightly above this one, and these are coronal images, posterior, middle, and anterior aspect. The superior band is the larger one, and that's what it looks like. This is the one that we see more easily, regularly seen. But just below this, you will see an inferior band, intimate or closer to the calcaneofibular ligament, which accounts for a second dot that you can often see in them right here. So 2 dots are seen. So to be certain it is normal, it should look normal in 2 consecutive axial images. When you go ahead and do an arthrogram, as we did in this particular cadaver, and you inject contrast in the joint and you fully distend the joint, the capsule of the ankle joint spills over these ligaments. So you're going to see contrast material in front of the anterior talofibular ligament and posterior to the posterior talofibular ligament. You should not think that that indicates leakage of the contrast from the ankle joint. Here in the sagittal plane, you can see beautifully what the anterior and posterior ligaments look like. The third of our lateral ligaments is the calcaneofibular ligament. And this ligament is obliquely oriented, attaching, as I've already indicated, to a bump on the posterolateral surface of the calcaneus that's of variable size. We've mentioned the ligament crosses both the ankle and the posterior subtalar joint. Its obliquity varies according to heel position, as you can see there, and it's intimate with another ligament that very few people talk about, yet it is important for the lateral stability of the posterior subtalar joint, and it is the lateral talocalcaneal ligament. This is showing you nicely the calcaneofibular ligament here in a dissection. This is the calcaneofibular ligament. Right in front of it is the lateral talocalcaneal ligament. Now, the reason I mention that is you can mistake the lateral talocalcaneal ligament for a normal calcaneofibular ligament when that latter ligament is torn. So they will look a little bit different. Based on some research that one of our fellows did, this is the calcaneofibular ligament. Right in front of it, the lateral talocalcaneal. And on coronal images, the lateral talocalcaneal ligament can simulate the cervical ligament within the sinus tarsi. We go to the coronal plane. This is in a cadaver, so the contrast is not so good. But here is the calcaneofibular ligament, so it's kind of grayish here, but it's this ligament. Here's the posterior talofibular. Superficial to the calcaneofibular, we have the peroneal tendons, brevis and longus. We go to the transverse plane, posterior subtalar joint. This is the calcaneofibular ligament attaching to the bump on the lateral surface, extending upward deep to the peroneal tendons. You won't see it on a single axial image. You've got to trace it upward on consecutive axial images. If there is a significant injury to the ankle joint or even to the posterior subtalar joint, the contrast material or fluid within those joints may indeed leak through the injury, through a torn calcaneofibular ligament, and end up in the tendon sheath of the peroneal tendons. So a secondary sign of injury to the capsule and calcaneofibular ligament is a joint fluid or a contrast material within the peroneal tendon sheath. This is an example of a large bump, probably abnormal due to chronic tensile force, where the calcaneofibular ligament attaches to the calcaneus. Usually the bump is very small. To complete our story of these lateral ligaments, another structure has been identified, and in the view of some, is a ligament. This is called the fibulo-talocalcaneal ligament of Rouvier and Canella-Lazaro. Has anyone heard of that? And Canella or Lazaro are not here, I assume, right? Okay. I'm not sure if this is a ligament. We, again, have had research fellows who have looked into this. This is what it looks like. It has an upper stem, a superomedial lamina, and an infero-posterior. I wonder if it looks like a ligament because the aponeuroses that are seen back there become thickened. But if you go to the literature and look it up, you will see some articles that indicate it is important. To give you an idea of what it looks like, again, taken from the work of one of our previous research fellows, the three areas of the ligament are outlined here in the coronal plane and in two axial planes. I think this is probably pathologic. That's my own feeling, that these are aponeuroses that have thickened, but you will occasionally see these linear structures in the posterolateral aspect of the ankle. We move on now, and we will talk about the medial ligamentous complex. Here again, unfortunately, there is considerable disagreement in the literature. It seems like everybody agrees, however, that this is an important ligament and is a layered ligament. So people talk about a superficial part, which is shown in red here, and a deep portion, which is shown in blue. The descriptions of what make up the superficial and deep part of the deltoid ligament, however, vary from one author to another. I'll try to go through that briefly. We go back to our colliculi, and you remember I mentioned an anterior colliculus, an intercollicular groove, a posterior colliculus, all right, which we described earlier today. Gray, when he evaluated the deltoid ligamentous complex, said that there was only one deep part, a deep anterior tibio-talar ligament, and then there were several superficial parts superimposed on it. That was Gray's concept of the deltoid ligamentous complex. Another important investigator, Pankovic, in 1979, had a different take. He and his co-authors indicated there were two deep portions, a deep anterior and a deep posterior, and superficial to them, several of the superficial ligaments were also found. So there is disagreement, but based upon most descriptions, the deep portion of the deltoid ligament is composed mainly or solely of ligaments that run from tibia to talus. A posterior part, which is the strongest part and the most important part of the deltoid ligamentous complex, and a less consistent, not as strong anterior part. You'll note here that both together attach mainly to the posterior colliculus and the intercollicular groove, that any attachment to the anterior colliculus is minor. So this then, the deep portion. Most authors would agree that the superficial portion of the deltoid ligament complex is very wide, is attached mainly to the anterior colliculus, and spans a distance with fibers that go as far anteriorly as the navicular bone, perhaps going to the talus, to the spring ligament, to the sustentaculum tali. That is a long, broad ligament. And most people would agree with this. So superficial, more anterior on the medial malleolus, deep, more posterior on the medial malleolus. Hence, when you look at a section in a cadaver, this would be superficial. Deltoid is oriented the same way. Here is the deep deltoid attaching to the intercollicular groove and the posterior colliculus. Then things get a bit confusing because there are various components then of the superficial and deep part, and some of these are fairly consistent, some of them are not. The literature is not uniform on this, but if you look at the distribution of the superficial deltoid, again, attaching to the navicular, to the spring ligament, to the sustentaculum tali, and perhaps even further back to the calcaneus as well. So let's look at some pictures. Here in a cadaver, we're looking at a coronal image. This is fairly posterior. This is the deep posterior tibio-talar portion of the deltoid ligament. You always see this. You always should evaluate this. It runs medially and attaches to this concave area on the medial aspect of the talus. We see here superficial portion attaching to the sustentaculum tali, which is this structure. Between the two, in this particular cadaver, there are some fibers. It's not clear if these are superficial or deep fibers between the deep and superficial regions. So this is what it would look like. A little more anteriorly, this is the deep anterior portion of the deltoid ligamentous complex. Here is the superficial portion running between the tibia and the sustentaculum tali. The tendons are superficial to that. Exactly what this structure is, it's probably a part of the spring ligament, part of the superficial deltoid, but I'm not sure. In the transverse plane, this is the deep posterior tibio-talar portion of the deltoid. This is the superficial deltoid curving around, going as far anteriorly as the navicular bone. In the next axial image, slightly lower, we can see mainly superficial deltoid ligament extending up to the navicular bone. In a patient, normal structures, the deep posterior, the image on your left labeled with an arrow. On your right, the deep anterior tibiotalar portion. Remember, it's not as strong and it's absent in some people. It is not as consistent. Here are injuries to the deep posterior portion of the deltoid, abnormal signal. We'll talk more about that. Here's the deep anterior part that looks abnormal. It's hard to follow to the talus, and in the sagittal image, the abnormalities extend from the anterior colliculus all the way to the posterior. All of this is abnormal. Involvement of both, of all portions of the deep ligament. We move on to our third area, and that is the syndesmotic ligamentous complex, of which there are 4 ligaments. The interosseous ligament, which is a continuation of the interosseous membrane, it's here. The anterior tibiofibular ligament, shown here. The posterior tibiofibular ligament, shown here. And the lowest one, called either the transverse or inferior transverse ligament, shown here. So when we check for syndesmotic ligaments on an MR, we don't stop with the tibiofibular ligaments. We at least look for the transverse ligament, and in some cases, we also can see the interosseous ligament. Let's look at these components. The first of these, and probably the most important in terms of injuries, is the anterior tibiofibular ligament. This is a short oblique ligament running up between fibula and tibia, right here. Now, this is an interesting ligament because, again, it is not a single band. Most descriptions indicate it has 2 or 3 bands of tissue. So when you look at it here in the coronal plane, it is normal to have these separate bands with high signal in between. In this particular patient, 2 bands are seen. And here's what it would look like in the axial plane. You can see an anterior band, and then there's some more tissue back here. We're seeing a part of a more posterior band. This is what they look like. Here's the coronal image showing you the 2 bands. One of our research fellows looked into the anatomy of this ligament and found that it was not unusual to have more than 2 bands, that one could have 3 or 4 bands, shown very nicely in this coronal oblique plane. You can see it here and see it here as well. So this can have multiple bands of tissue. Here is another example. This is the lowest band, and as she found in her investigation when she looked at the anatomy, the lowest band may be large and be more horizontal. Now this is of some interest because of the existence of another ligament that goes by the name of Bassett's ligament. How many have heard of that? Some people in the room. There is a debate exactly what is Bassett's ligament. Some people think it's a fascicle of the anterior tib-fib ligament. Some people think it's an anomalous ligament. I'm not sure, but I do know when there is a ligament below the usual region of the anterior tib-fib ligament that curves over the corner of the talus and is this thick, it's probably a Bassett's ligament, which is a cause of anterolateral impingement of the ankle. So you want to at least look for this, particularly in someone who has signs of impingement. But once again, a secondary finding might be edema in the subjacent talus. Bassett ligament, here's what it looks like in the axial plane, this structure and this structure. This is what it looks like in a sagittal plane. It looks like an intra-articular body. Another example, that is a Bassett's ligament in front of the tibia. Here's what it looked like in the axial image. The posterior tibiofibular ligament is the mirror image of the anterior tib-fib ligament. It is located here, all right? This ligament is also well shown on our MR images. It often looks like a triangle with a superficial and deep component, wider on the fibular side than on the tibial side. In this dissection, again done by one of our fellows, this is the area of the posterior tib-fib ligament. This is the posterior talofibular ligament, and we're seeing a part of the interosseous syndesmotic ligament up here. The inferior transverse is the third of our syndesmotic ligaments. It's an interesting ligament because it is low and hangs down behind the talus. It is almost meniscus-like in its configuration. This, when thickened, is a cause of posterolateral impingement. You can see that sometimes on your coronal images. And so it's an important ligament to look for. To give you an idea of what it looks like, here it is. This is the inferior transverse ligament. It is this ligament hanging down below the tibia, covering a little bit of the talus. And this in the oblique image shows you that ligament. So you will see this regularly. We see it on almost all of our MR ankle exams. And then finally, an interosseous ligament, which some regard as the strongest of the syndesmotic ligaments. I kind of tried to figure out what it would look like in 3 dimensions as this red area intimate with the syndesmotic recess of the ankle joint. Our research fellow found some beautiful images of it in cadavers. This is what it looks like. It extends laterally from a proximal tibial position to a more distal fibular position, and you can see it sometimes in multiple segments because it's not just a single band. Here's another one. This one looks kind of flimsy, but that is the interosseous ligament shown there. And one further example in another cadaver showing you this interosseous ligament. So let's go ahead and look at some images and sections and see if we can figure this out. This is a coronal image. Fibula comes down, then we have that constriction, and then the tip of the fibula. This then is the posterior talofibular ligament attaching to this part of the fibula. This lowest ligament is the inferior transverse, shown over here in the image. And this is the posterior tib-fib ligament located above it. In the axial image, this is a tough case because we are cutting right through the level of the ankle joint, but this is tibia, this is talus, this is fibula. This is the posterior tib-fib ligament, like here. This is the inferior transverse ligament, okay? And then as we get a little bit lower, we can see here that we are seeing that the posterior tib-fib and inferior transverse ligaments, and then this ligament here is the posterior talofibular ligament. So if you take your time when you look at these, you can sort this out. So the proper level for looking at syndesmotic ligaments is above the level of the ankle joint, or rarely at the level of the ankle joint. The fibula has a straight inner margin. Proper level for looking at tibiofibular ligaments. The proper level for looking at talofibular ligaments is below the level of the ankle joint, where the fibula has a concave margin, and you can see here the anterior and posterior talofibular ligament. So this is the proper level for the posterior tib-fib. You can see it here. Fibula has a straight margin. This is the proper level for the posterior talofibula, which is shown here. Let's finish up in the last 7 to 10 minutes by just touching a little bit and quickly on the function of these ligaments. The anterior talofibular ligament is taut in plantar flexion, as I indicated. It limits anterior translation of the talus or posterior translation of the tibia, and it limits internal rotation of the talus. The posterior talofibular ligament is taut in dorsiflexion. Its functions are to limit posterior translation of the talus or anterior translation of the tibia, and in addition, it limits external rotation of the talus or internal rotation of the fibula. And the calcaneofibular ligament, which limits anterior translation of the talus with dorsiflexion, and we indicated why dorsiflexion was important, and limits internal rotation of the talus and external rotation of the fibula with dorsiflexion. So it is functions in the position of dorsiflexion. Now, finally, a couple words about these two clinical tests that are used to study ankle stability. This is a talar tilt, which is done as a varus stress to the ankle with either neutral or plantar flexion of the foot. This is a talar shift with one arm stabilizing the distal tibia, the second hand lifting the talus anteriorly. You have to come up and try measure these. It is not easy. Typically, the talar tilt is done in 30 degrees of plantar flexion. You draw a line along the top of the talus and one along the articular surface of the tibia, and they're almost parallel. And indeed, you can see that it's less than 1 degree in 90%. If this angle measures more than 5 degrees, it's probably abnormal. In terms of the talar shift, you have to, in fact, draw lines that are tangent with the posterior surface of the talus and the posterior surface of the tibia. The talus translates forward, this distance increases, and this is done in neutral and 30 degrees of plantar flexion with these as the values cited in the literature. So how good are these, okay? Well, if you have a tear of the anterior talofibular ligament alone, typically, there is a positive anterior talar shift and a negative varus talar tilt, except in extreme plantar flexion. So this is the kind of picture you would see. You can see the talus is shifted forward in the neutral position. This results in widening posteriorly, which is called the hiatus sign. This would be a good finding for isolated anterior talofibular ligament injury. If you have an isolated tear of the calcaneal fibular ligament, typically the tests are negative. So injury to this ligament alone may produce negative results on provocative testing. And if you have combined tears of the anterior talofibular and calcaneal fibular ligament, you get a marked anterior talar shift and a positive varus talar tilt. Okay, sorry, and this is what it would look like. You can see this markedly exaggerated tilt with varus testing. And here's an example where even on MR, the talus was translated forward. There is the tearing of the calcaneal fibular ligament, at least partially torn. Here's the tear of the anterior talofibular ligament. With regard to the deltoid ligament, it functions as a single ligament. I mentioned the superficial layer attaches to multiple bones. The deep layer attaches to the talar body. Deep layer is the strongest layer. It prevents lateral shift of the talus and limits dorsiflexion at the ankle. And it forms something, a medial part of a ring that I'm going to talk about after the coffee break.